Hello everyone. So coming on to the last entity, which is the cancerous one. As you all know, it is an umbrella term which includes both the non-invasive as well as invasive epithelial tumors and neoplasia of the ocular surface. So my topic is management options. I'll take you through few cases of mine and see how we managed it. So she's a 70-year-old female presented with the typical nodular, gelatinous and translucent type of mass in the limbal area, in the interpalpebral area. So thought of OSSN and thought of starting her on MMC. After 1 week, see the result. Very good improvement, only just after 1 week of MMC. After 2 cycles, that is 1 week off MMC and then the second cycle of MMC, further reduction. This is the effect after 2 MMC cycles. The right side is at the presentation and the left one is after 2 cycles of MMC. This is the reduction after 3 cycles, still the staining is present. After 4 cycles, dramatic improvement. However, as we further on continued with the therapy, patient developed what we feared, the epithelial toxicity because of MMC. So we had to put patient off MMC, we put a BCL on it, but see, after 1 month, the OSSN recurred. So this is the bigger monster which we feared, but then we had to change our action plan and then planned a conjunctival autograft from the non-involved eye to the involved eye, excise the OSSN. The problem in such cases is you don't know how much clear margin you should take. You should consider the initial picture or the picture which was present when the tumor recurred. But however, 2 mm clear margin on the corneal side and 4 mm on the conjunctival side was taken in this case, and the autograph was taken from the uninvolved eye. So always in cases of OSSN, the provisional diagnosis can be made clinically, and gold standard obviously is histopathology. Now after OCT has come up, we all know how normal corneal tear film, the hyperreflective epithelium looks, the normal basement membrane and Bowman's membrane complex looks here, and the corneal stroma looks. So in cases of, this is the picture how normal limbus looks on OCT. The corneal epithelium, this is the conjunctival epithelium, this is the tenons, which is more hyperreflective than the epithelium, and the stroma. So in this case, we did anterior segment OCT2. This is just to take you through after surgery. One must label the biopsy properly so that the pathologist can help us whether the margins are truly involved or not. And label them like this, put them in a petri dish, put that paper and send it to the histopathologist. This is the histopathology of that patient. You can see loss of polarity and hyperchromasia here by this blue arrow, and the posterior margin and the basal membrane is free. So this is partial involvement. This is thank you.
No,
so
that's
this
okay,
is partial involvement. I'll just take 5-7 minutes, I think. And on 40x, another features of moderate dysplasia are seen. 4x magnification, I just wanted to emphasize that as on anterior segment OCT, you can see abrupt transition from normal epithelium to abnormal epithelium. See the dysplastic epithelium here and the normal epithelium on the right side. Dr. Carol Karp, she's a name in OSSN, all of you must be knowing her. So she has done a lot of studies how histopathology connects well with anterior segment OCT. And now, features of OSSN which we can see on anterior segment OCT are epithelial thickening, which is acquired hyperreflectivity more than what is seen on normal corneas and conjunctivas, abrupt transition from dysplastic epithelium to normal epithelium, and distinct plane between the lesion and the underlying tissue only seen through the thin lesions. And features to rule out OSSN are epithelial thickening, less than 142 microns, and presence of epithelium over the lesion. So which means that the lesion is subepithelial and not coming from the epithelium. So see the hair, this is the lesion this is epithelium, and epithelial thickening is seen and is more reflective than the normal one. This is the corneal epithelium, and this is OSSN. Again, see the distinct demarcation line between OSSN. So NTA segment OCT can be done to diagnose cases and for follow-up of cases, whether it is recurring or not, and post-operatively to see how is your result. As in this patient, this is the patient 1 month post-op after conjunctival autograft, and this is the OCT 1 month post-op. She is still doing fine. This is 6 months post-op, and now after 2 years post-op, she is fine. This is another patient, 69-year-old male, presented with small mass hair, translucent. We did a OCT and found this again hyper-reflective zone at the limbus. Patient was started on MMC again. There was distinct response to MMC, but patient was lost to follow-up, and he thought that the lesion has resolved. And this is just something which is left out of the lesion. He didn't come back. The OSSN progressed, and okay, here I wanted to show you that in corneal NTA segment OCT, you can see hyperreflectivity again. This is pre-MMC and this is post-MMC. So the reflectivity decreases as the lesion starts to resolve. Again, we did excision, but in this case, amniotic membrane graft was done. So I feel that conjunctival autograft, obviously, because of the limbal stem cells, it fares well over amniotic membrane. This is one more patient, 55-year-old female. Again, excised, sent for histopathology, but it came out to be herpes HSV papilloma, and it didn't turn out to be OSSN. So this is a differential diagnosis which one must keep in mind. A 45-year-old male presented with typical OSSN type of features, started on MMC. This is post first cycle of MMC. So the lesion was decreasing, and this is 3 weeks after presentation. Lesion was decreasing, but see what was happening. The sclera was melting and there was some mass coming here, another growth coming up. 2 weeks later, patient presents with this. Absconded for 2 weeks and comes with proptosis. So investigated HIV positive patient, suspect HIV when the OSSN progresses really fast in young male patients. So take home messages which I wanted to give all of you is, suspect OSSN is common. It is the third most common ocular malignancy after choroidal melanoma and intraocular lymphoma. Don't think that this is pterygium, small tenons or small tubercular lesion or something. Recurrence is directly proportional to completeness at the time of excision. It is not directly proportional to the dysplasia present at the initial time of presentation or in histopathology. Fast progression, always and always think of HIV. I think all OSSN patients, we should get HIV done. And fourth, follow-up should be lifelong, because the basal potential in the patient of getting a carcinomatous recurrence is very common. So annual follow-up is must. Thank you, all of you.